Thank you to everyone for joining our webinar today. Our focus for discussion is rural epilepsy care and rural rares, hosted by the Epilepsy Foundation, with support from Jazz Pharmaceuticals, Ultragenics, and the Rare Epilepsy Network, or REN partners. I'm Dr. Kathleen Farrell, Vice President for Public Health and Outcomes at the Epilepsy Foundation, and I'm very excited to introduce our presenters for today. Those are Dr. Nathan Fountain, Director of the Epilepsy Program at the University of Virginia, Diane Carter, Epilepsy Care Coordinator at the University of Virginia, Lacey Jaroski, a mother of a child with SCN8A epilepsy, Glenna Steele, who is Executive Director of the GLUT1 Deficiency Foundation, and Roxanne Kogel, Executive Director with the Epilepsy Foundation's regional teams. Your questions during our webinar today are very welcome and encouraged, and I'd ask you to please submit these via the Q&A function in this Zoom. We are recording the Zoom, and it'll be made available in the coming weeks via the Epilepsy Foundation's YouTube channel, and we'll be sure to share that with you all. Dr. Fountain, you're welcome to begin.
Thank you, Kathleen, and thank you to everyone who's joining us today. Really, my job is to kind of give you a case study of rural epilepsy care. So let me share my screen with just a few slides. I promise I won't bore you, but so much with the slides, but I think some of the things I'm going to talk about put things in a better context. So hopefully you can see that now. And you already heard Kathleen introduce Diane Carter, who's going to follow up with some of my comments. And Diane, please feel free to interrupt with anything I'm saying that needs modification. I thought I'd just take a few minutes to talk about our main clinic versus our field clinics. And field clinics is where we do rural epilepsy care. Although, as I made the slides, I realized that while I'm at home at the University of Virginia, which is a large medical center, we are in a rural area. So the university town of Charlottesville in Virginia, the city, the county, and the surrounding 5 counties together, I think only have 150,000 people. So I guess you could say I always deliver epilepsy rural care, but that's not really what I'm talking about. I'm talking about delivering it away from the main station out in what we call the field clinics. I'll just mention some barriers to rural care. I'm not going to talk about all the things that everyone knows about, many common barriers to rural care, but some things that specifically we have to pay attention to overcome in conducting rural field clinics for epilepsy. And then some unique aspects of care coordination that Diane's going to talk about. And then finally, funding, which is the thing that everyone ultimately focuses on because you can't get very far without funding. I'm at the University of Virginia, and this is the main medical center here. This is the main hospital building with a new annex, a big parking garage. And so it is kind of rural. If you look out in the hinterlands here, there aren't a lot of other people around, but we are a major medical center. And in Charlottesville, at the main center, we have a main epilepsy clinic, and that would be conducted like any other tertiary care clinic or university clinic you might know about. We have an epilepsy monitoring unit, which is an inpatient unit for performing video EEG. So patients are admitted to the hospital, EEG wires glued to their head, and we capture seizures by live video EEG. We have an EEG laboratory where we conduct EEGs and other similar kinds of studies. We have an epilepsy surgery program where we evaluate people for epilepsy surgery and ultimately perform it. And we have a clinical research clinic, and that kind of plays in a little bit to what we're talking about. So that's the main clinic. And if you're familiar with any epilepsy clinic or tertiary care center, it would be pretty representative. I guess actually comprehensive epilepsy programs originally were developed at the University of Virginia by my predecessor, Fritz Dreyfus. So we have kind of a typical program, I guess you'd say. And that means in Charlottesville, because it is relatively straightforward compared to some other major medical centers or tertiary care centers, we have a single clinic building. That's this building over here, not this little hub here, but it goes into this building you can't quite see, probably off to the right of this. Continuity in our clinics is maintained by a fellow and attending. That means, so for example, the clinics that I staff, I'm the attending physician, but we have 5 epilepsy fellows, which are neurologists training for specialty care in epilepsy. We maintain continuity by them as well. So throughout their 2 years of training, they'll always see the same patients, or the patients will always see them, and see the same attending throughout all of history, as long as the attending's around. And I've been here for 34 years. So that's how I maintain continuity. At the main university center, we have access to all diagnostic and treatment modalities. So in our case, we perform everything possible, as well as experimental therapies. But there's some things about that to know that are self-evident the very first time you've ever been to any major academic medical center. It's true for everybody, but particularly if you come from a rural area. Parking is difficult. So I showed that picture that we have this huge land mass around us we could build in, but of course, because we're an institution, everything's very tight. So parking is difficult. It's complicated. Registration is complicated at our hub at the university, where you have to actually register twice for reasons unbeknownst to me. And the hospital and clinics are really not well marked if you're not familiar with tertiary care medical centers. So those are things that everyone experiences that are important about the main clinic. Whereas any field clinic, as I'll talk about in a minute, the way we conduct them, it's near home, and that's just pivotal. The continuity is maintained by the attending, and I think that's really important for all kinds of care, but particularly in this context. We get most of the testing at local hospitals, although we send people to the main university hospital when we need to. And it has easy physical access in our field clinics. They're held in the local health department building and have familiar staff. And that all really helps promote the field clinic. And those are not things specific to epilepsy, but epilepsy goes along with a lot of other things that is important for, like being near their home. So just to put you in perspective, in this map of the United States, you'll recall Virginia's here by Washington, D.C. up here. And this is a blown up map of Virginia. Just for context, this blue star in the middle of the state is where the university is in Charlottesville. And because Virginia is a triangle, it's a long way down the interstate here, down to by Tennessee. This is Bristol or Abingdon, Virginia, where we have one field clinic. The other one up here is in Wise, which is up in the mountains, a rural area, and this one in Tazewell. So from this star to this star is 309 miles door to door, from my door to that door. So the clinics are far away. It's just the nature of the peculiar way Virginia is constructed that they're so far away. They're in rural Appalachia. And despite being far away, despite Diane living in the same community as the clinics, we provide really highly coordinated epilepsy care. Practically, the way it works is once a month, an attending, so for instance, me, with a fellow and a resident, that's someone training in neurology, get in the car and drive down there and stay for a couple of days and see patients all day, once, as we would say, up in the mountains. So one of these two clinics, and the next day come down and see patients here. So one day of clinic up here, one clinic down here, and then drive back to Charlottesville. And that's just to put this in perspective. We leave on a Tuesday, come back on a Thursday. That's sort of the practicality, give you an idea of how that works from our perspective, the physician perspective. And a number of cultural aspects of rural care, I would say, they are kind of barriers, but they're not just barriers. Sometimes they're actually helpful, but also there are things you have to consider when delivering rural care, particularly rural epilepsy care. Of course, rural areas by definition are sparsely populated, so there's long travel times. And who wants to drive 5 hours to go to the clinic? That seems almost crazy, doesn't it? But of course, you have to recognize that's amplified 100 times or maybe 1,000 times when you have someone with you, a child or an adult that has severe neurological impairments. Maybe he's on a ventilator. So driving 5 hours down the road when they might get hypoxic and desaturate, have a plug that needs to be cleared, need to be suctioned, or just have a seizure on the way. Those are really dramatic things. So the long travel times is particularly important for delivering rural epilepsy care because it gets people to come to the clinic if they don't have to travel far. The poor economic status is important, at least in our case. It's a relatively poor area in Appalachia. And it really, our rural population is a minority of the country. It's only 20% of the country. The other 80% of people live in what are defined as urban areas. So it's a kind of underrepresented minority in a way of people who just can't, they kind of get neglected by the larger system. There's a great attitude in our community and probably most rural communities of self-reliance. And that's great because there are people who will get things done, but also it means they might be reluctant to even go to the doctor because they're relying on themselves. They're family oriented, which also provides a great support network, but it also means they may feel like they're the person in charge, the mom in the family who shouldn't be sick, or the dad who needs to go to work, or a child who doesn't want to be embarrassed by having something that might have a stigma. So being family oriented is important in both ways. Homogeneity of language and culture and customs is in some ways really great because then you kind of know the people you're dealing with in a way. But on the other hand, it means if you have something like epilepsy that's stigmatized, it's stigmatized broadly across the culture possibly. People in most rural areas are polite to their neighbors, but kind of suspicious of outsiders. I think it's kind of funny because I guess I'd be an outsider, but I've been going to Southwest Virginia so long, I never think of myself as an outsider. At least they don't seem to think of me as an outsider. But I think that's important, particularly when you're setting up a clinic if you don't live in that community. Of course, if you live in the community, you're not an outsider, but you're going to have an epileptologist, for instance, sort of necessity, they're going to come from a larger urban area. There's a big importance of church and religion, which isn't typically a problem, either good or bad, except in the aspect that in a few cases, that might lead to religious beliefs about epilepsy or how to treat it. And that might be an issue. In some areas, I'd say people are possibly less medically sophisticated. I'm not really sure that's so very different than everywhere else. All of us kind of have a challenge in medical sophistication nowadays because it's so complicated, but it's probably greater in rural areas. There's also slower, more direct communication. Sometimes this is unappreciated. So I'm firing off right here. I'm not a New York speaker, but I'm going right at this to get your information out. But if you're trying to have someone understand this in a rural area, you might have to just make sure they understand one thing at a time. It's not because they're slow. It's because the normal style of communication is to say something, make sure it's understood, then move on to the next thing. And in a busy clinic, you have to be sensitive to that. I read somewhere someone said culture is simple in rural areas. I'm not sure about that. It's different. I don't think it's simple. I think it's complicated, maybe more complicated because you know your neighbors so well. But the idea is you have to pay attention to culture. There's a great connection to the outdoors, and that's not really a barrier at all. I find that less of a barrier. I like the outdoors. I'm an outdoors person, so that's a way I can connect with people, but you have to be aware of that, particularly if they're wearing camo into clinic all the time, for instance. That doesn't mean they're if you're in New York City and wearing camo to clinic, maybe that would mean something different. But in rural Virginia, that's what everybody wears, sort of an outdoor hunting, outdoors culture. And then something else important to consider when you think about this is smaller pool of nurse and staff applicants. So when Diane one day retires, I'm going to cry for a long time because it'll be really hard to find someone as fantastic as Diane. And that's just generally true across the board, particularly for what a fantastic job Diane does, but there's just a smaller pool of applicants. One way we keep track of seeing patients in the field clinics is by this database. And this database is a way to keep track of patient information. And the reason it's important is because you really have to see a lot of people when we go. We have to see a lot of patients because there's a big demand and there's not a lot of opportunity. And so the way we do that with this database is by tracking their seizure frequency over time. So the details of this don't really matter, except to say that before you go in the room, you could look at this summary, understand sort of the vital statistics, what the patient's history is or what's going on before you go in. Now, of course, there's a lot more to it than that. But in terms of understanding how their seizures have changed over time. So for this patient, we started the database in 1999. So this goes from April 2000 to up to today. And so we track their seizure, each type of their seizures and how frequent they are, and when they started their medications and stopped them, and their previous imaging, so MRI and things like that, and previous EEG, and their video EEG monitoring. And so this really allows us to see patients very efficiently and very thoroughly, more thoroughly than you could at a tertiary care center. So the database, from my perspective, is key to providing good care, good longitudinal care. And some logistics. I mentioned we have to see high volume historically just because of the large demand. And that really requires an efficient model and efficient people. I think continuity of the physician is really helpful, and continuity of the data, as I just demonstrated. And that care coordination outside of clinic hours is really the key to providing high quality care. A lot of things happen separate from the physician that are vital to the care of people with epilepsy. And just as a general principle, you really need buy-in from the local community. That's helpful, but it's absolutely required to have buy-in from funders. So the people who fund your endeavor have to think it's worthwhile. And then as far as rare diseases go, as a subgroup of epilepsy or related to that, there's some things that are important in their care that make it easier to do in field clinics, and some that make it harder. In our case, rare disease is actually more common in our field clinics. So you might be familiar, for the people with a medical background, that Emery-Dreifuss dystrophy was, my predecessor is Fritz Dreyfus, and so that was discovered as a result of field clinics because of concentration of families. He was easily able to observe that, and that persists to today. But in field clinics, there's fewer resources to deal with complex problems. There's lack of access to reliable diagnostic testing. So we're fortunate that we have pretty good diagnostic testing, but only up to a certain level. And you really, in our case, have fewer visits to address active or evolving problems. So we only go to field clinics once a month. So in between that time, we can have communication, and Diane, in our case, does the coordination, but we aren't there to have a clinic visit. And so we're more dependent on care coordination. On the other hand, of course, in our field clinics, you get access to specialty care near your house you wouldn't otherwise. And I know many of our patients simply wouldn't follow up if they didn't have a field clinic. And that reduces the complexity and risk of travel that we talked about. And you may get more personal nursing care in some ways. And the use of our database reduces redundancy to help clarify past workup and treatment. So that was really kind of a lightning force introduction to what we do and how we do it. And I thought I'd take a few minutes to see if Diane has any comments about care coordination.
I'll add a few things and then you all can ask questions if you need to. Our service area in Southwest Virginia is covers 12 counties and 2 cities. And even though we're in the tip end of Southwest Virginia, our patients travel quite a bit just to get to our 3 field clinics. Some of our patients even travel 2 hours just to get to the field clinic. If we have a patient living in the farthest end of the county to go for an MRI, it may take them 3 to 3.5 hours to get to Johnson City for a pediatric sedation MRI. So there's still travel and a lot of care coordination, but it does open the area up for a large number of epilepsy patients to be served. One of the things Dr. Fountain didn't touch on is that we have been in existence since 1967. Dr. Dreyfus started the clinic. So, no, I'm sorry, not 1967, about 67 years, Dr. Dreyfus started the clinic. So we've had a lot of trials and failures of how to get the clinic going and provide good care coordination. I don't think that it started with me for sure. There was a lot of people behind me, and the biggest improvement, I think, was 20 years ago, the year I came on. We partnered with Virginia Department of Health and the Title V Maternal Child Health Grant. So we work with that staff and in that entity to care coordinate patients with special healthcare needs. And in that clinic, we see neurology as well. So we offer in our clinics a multidisciplinary team, and everybody down here is from Southwest Virginia and knows the area. So we have nursing team members, we have the clerical access staff, we have a nutritionist, we have a dental hygienist, we have educational consultants with master's degree in education that's been in special ed. And we've had a social worker in the past, but that position's not open right now. So we have different disciplines that can reach out and help these patients and also see them while they are in clinic. Our clinics entail, even though I'm the only nurse that care coordinates, we do have 22 on-site clinics a year. Let me let you know that. And we'd offer 12 plus telemedicine clinics a year. And I'm the only nurse in the care that does the care coordination on this end. That seems like a very few clinics, but it does keep me really busy to care coordinate it before clinic, to get things ready before clinic, to order testing during clinic, follow up with testing, do patient teaching and exit interviews in the clinic to review meds and med changes, and then to follow up post-clinic. I think that's all I really have to add, and I will be available for questions and help answer, hopefully. Thank you.
So just as a final slide to talk about funding, and I guess it's important in my mind, thank you, Diane, first of all, for all of those things, but also funding to keep a bit separate in my mind, because it's, you know, your goal has to be to provide the clinic first, and I guess you think about the funding second. But the way our clinics work, as Diane was saying, is the Virginia Department of Health provides us a grant. The UVA, the University of Virginia Health System, provides the grant. That's the hospital. The Department of Neurology pays for the faculty and fellows and residents part of it. And then we do get some clinical revenue that goes into the pot. And finally, the local health department. So our clinics are held in our Virginia Department of Health buildings, and they're very generous in providing their space and time for us. We pay, I think, $5 a visit in one, for instance. It's really, one is free, I think. So it's really helpful to partner with the local health departments. And these pictures are just to remind me. So this top picture is looking down Main Street in Wise. So if you went to the end of this picture and turned left, you'd go in the health department. And then at the bottom is Abingdon, which is where our main field clinic is, which is a beautiful town. This is right by the old Barter Theater. And the reason I put this in here is to remind us of these areas. And in most states in the United States, there are people who want to provide rural care to these communities, just like this one in Wise up here. You would think they wouldn't, because they're not highly populated, but our experience is that if you're able to go to the people involved, and particularly the representatives from those counties in your state, that you can get more access. Although, as Diane mentioned, the Department of Health grant actually comes from a federal block grant. And the strategy for funding has been really to have a long-term source of funding. So I'm glad Diane mentioned it. For 67 years. So Dreyfus started the clinics in 1957 and attended him till his death in 1997. And then I and my partners have been going ever since. And that really is because we have demonstrated utility. And what do I mean by utility? Well, as far as the funding goes, the Department of Health recognizes there's no other specialty care. So our argument is there's no other specialty care, so please fund us, we can provide this, and that's been helpful. And then we've actually provided the care. The hospital, the UVA health system, recognizes that patient referrals come to the hospital from there. About 15% of our epilepsy unit admissions come from our rural field clinic. And then visibility. So within the Department of Neurology, the field clinics are somewhat legendary. So if you ever meet anyone who ever trained in neurology across the world, probably the first thing they're going to do is have a sort of a war story about attending the field clinics, because for doctors in training, it's a really fantastic experience to go out in the community to provide direct help to people in the community, particularly in rural communities. So that visibility has to be there to help the funders to then provide the funding. So that's a kind of a summary of our clinic in terms of the funding, the staffing, the care coordination, the cultural concerns as background for our discussion.
Thank you so much, Nathan and Diane. And I know your presentation and some of your comments are already generating some questions. One that I see that's particularly pertinent here is, you described the logistical distances and complexities in rural care. How has telemedicine or telehealth changed the outlook or the care possibilities for people living in a rural community?
Diane can address some of the details of this. We've been shamefully reluctant to provide telehealth to our field clinics, only for practical reasons, because we see so many patients, it was difficult to do that. But the pandemic, fortunately, forced us into it, and it's been a great addition. Although we started before the pandemic, we embraced it wholeheartedly during the pandemic. We didn't have in-person field clinics for a couple of years. And so now moving forward, the model to use telehealth in rural communities makes perfect sense. I'll tell you my personal perspective is that if I would prefer and always do see a patient in person first, whether it's in the field clinic or in Charlottesville. Follow-up visits can be by telehealth. And then I like to see them, at least if they have active epilepsy, at least once a year in person. And the reason isn't necessary to examine them. That's important for neurologists. If you've been a neurologist, we spend a lot of time examining people, but it's really because I think the communication is so much easier in person. Think about what you would get of us having a conversation in person right now instead of telehealth. So on the one hand, it's fantastic. On the other hand, I still think there's room for it. And Diane might be able to comment on its specific utility for us.
Yeah, I agree that after the pandemic forced us to use telemedicine, I was really surprised how many patients we could get on board with the visits in clinic. I mean, I think we kept our visit rate up just as high as when they came on site. So most of our patients can really use technology, especially their iPhones, very well to participate in the clinics. And our telemedicine clinic we do also that I mentioned earlier, the 12+ clinics, is by one of the peds neurologists. And we actually have the patients, what I call the traditional telemedicine. Patients still come on site here in our Bristol clinic, and we do we have a telemedicine clinic room where we do the visit with the pediatric neurologist, and she's at UVA. So these have been very good too, because we still have our multidisciplinary team here that can actually see the patients well, the team members I mentioned earlier. And this is a clinic where we bring in most of our really complex CP kids with epilepsy that have a lot going on. So it's easier for them to come in and not come in and have to sit in the clinic room and wait for a visit. So that's worked out well too.
Thank you for that. And while we'll continue to take questions for the clinical perspective, one other one that I'll add here now is, you have some co-panelists here that are very strong advocates in the epilepsy community, have loved ones with epilepsy, and I believe probably many of our attendees on the line for this webinar are in a similar position. selection of locations for rural field clinics, or, what has been your interaction with community members in advocating for this type of service? And I'm sure that varies by hospital and location.
Yeah, in our case in particular, they've been established so long. At one time, they were in all the communities in Virginia, each region of the state. The reason we're still out so far from Charlottesville. So when I tell people I go 300 miles door to door, they say, "What, are you out of your mind? That doesn't make," if I went north instead of south, I'd go to Pittsburgh. So I go to Pittsburgh to have a clinic. But the reason is because there aren't specialty care services there. And the other reason that is not so obvious is because despite its rural nature, we've had a very strong representation in the state legislature. And so they've been able to not exactly fund us. They haven't funded us, the state legislature, but they get us some visibility. And also the health department recognizes it. So there's kind of two aspects. One is the need, of course, and the other is the ability to fund it. So in terms of thinking about where to have a rural field clinic, it has to be centrally located, the people you want to service, but it also has to be someplace you can sustain. For example, Kingsport, Tennessee is right across the street from Bristol, Tennessee, essentially, just practically a stone's throw. We used to have a clinic in Kingsport, but we had it in a hospital who was very generous for 20 years or more. And then one day the hospital said, "We need that room and we don't have any more room for you." So they kicked us out of the hospital. Whereas the health department, we haven't had that problem because they have a larger mission to serve the people of the state. So I think it's a lot of things go into a rural field clinic. Getting doctors to go there is another challenge.
Thank you for that. At this stage, I'll ask Glenna to please share her screen and you can begin. And I'll encourage participants to please keep adding questions to the Q&A function here in Zoom. We'll make sure we get to all questions.
All right. Hello, everybody. Thank you for the chance to speak today. My daughter Macy was born in Orlando, not a rural area, in 1997. My husband and I had lived in Florida for the first 6 years of our marriage for his career as a golf course superintendent, but we were high school sweethearts from the same small community in the foothills of Appalachia. My husband's mother was diagnosed with cancer while I was pregnant with Macy, and she died 2 months before Macy was born, and her name was Macy too. We felt that pull to be back home, to be with our large and close-knit family, and we had regretted not being there to help when they needed us when she was sick. So we moved back home when Macy was 7 weeks old. We thought at the time it was to be of more help to them, but it turned out that we were the ones who would need the help, and they've been there for us in so many ways. Why wouldn't we just move away from this rural life with all the challenges you've heard about and we'll hear about today? Well, I've shared about family and their support and giving our girls the chance to grow up to be near them. We are 7 miles from gas and groceries and at least an hour from most specialty care, but we are surrounded by that family and farmland and fresh air and adventures and dogs and cats and litters of puppies and kittens and horses and a small town sense of community. And the lower cost of living can't be ignored either, especially when epilepsy takes such a toll on family finances too. Around Macy's first birthday, she started having unusual symptoms and eventually seizures at 22 months of age. And at 22 months of age, she got an epilepsy diagnosis. Medication after medication failed her, and some caused some really scary side effects too. After learning about the ketogenic diet, we wanted her to be able to try it, but we were met with stern resistance from her medical team and nowhere in our state where it was offered. We ended up having to switch to a new center 4.5 hours from our home to give her the chance to try it, and it changed her life. Eventually, when she was nearly 11 years old, we learned that the root cause of her epilepsy was GLUT1 deficiency, which is a rare disease where glucose doesn't reach her brain the way that it should. And it turns out that ketogenic diets are the standard of care. It took a lot of advocacy, effort, time, and money on our part to get access to the diet and to get a diagnosis for Macy. And we do wonder if her life and ours would be different today if we'd been able to make it all happen much sooner and much easier. But our story is not unique in the GLUT1 community or even the rare epilepsy community, though, and families in rural areas are at a huge disadvantage, both in terms of access to expert care, early diagnosis, and ketogenic dietary services if they choose to use that. But our struggles didn't end with the diagnosis either. Because GLUT1 deficiency is so rare, we traveled to Dallas, Texas, 1,000 miles away on a basis so she can be seen by an expert and be in the middle of research. We are very thankful to be able to do that, but it does come at the sacrifice of a lot of other things too. She does still need local care too, and that's been an ongoing challenge to be able to coordinate all the providers and support services that she needs. Some of these might not seem like direct healthcare issues, but they are often the intangibles that really do have an impact on health, on happiness, and the quality of life that everyone deserves. You've heard about some of these today, and you will hear about more, but we experienced challenges in all of these areas. When she was on the ketogenic diet, access to ketogenic diet supplies and specialty foods was an issue. Rural pharmacies not stocking specialty medications sometimes, or in special formulations like we needed with the diet, like no carbs. OT, PT, and speech services, and the lack of an overarching coordination of care for those things. Complicated emergency care when she needed it, or even routine care from pediatricians and dentists that have to be more local. A lack of supportive special needs options for sports and opportunities for things like ballet classes or music lessons. Those can be very specialized in larger areas for people that have unique needs, but not in communities like mine. A lack of a good fit curriculum in the school system and the special education program. And now that she's older, the transition to adult care has renewed many of these struggles. She has Medicaid as an adult, and there's a lack of portability for coverage. The ending of her school experience brought a loss of opportunities with few, if any, options to replace them. There are transportation challenges, not just for medical care, but for also access to the community. Reliable internet service is an ongoing battle for all of us, and there's social isolation for her and for us as caregivers. She's 25 years old now, and in many ways, she needs me now more than ever to help fill in all of these gaps. We've had to continually be advocates and educate others about her rare disease, even other medical experts, and things just seem to be much harder than they need to be. Her care seems to be very disjointed, almost like trying to fit puzzle pieces together, and nobody seems to be looking at the big picture. I would imagine this is true for many rare disease families, no matter where they live, but things are definitely compounded in rural areas. My younger daughter, Maggie, she doesn't have GLUT1, but she has had seizures and developmental delays as well with an unclear root cause. But she's shared many of these same struggles along the way that Macy has had, but has also had some that have been unique to her. We worry about today for both of them, but we worry about their futures too, and the difficult choices we'll have to make in planning for the time when we're no longer here to advocate for them. There's a real lack of options for supported living and programs, and those struggles are greater in rural areas as well, with having to leave the community they love and being close to their family members as the trade-off for getting those kinds of services. Even though at times we feel alone, we know there are many others in the rare epilepsy community who share these same struggles, and by working together, we hope to help find solutions. And thank you for giving us the chance to share my story today.
Glenna, thank you so much for sharing your story with your two daughters. I'm seeing a lot of conversation generated in the chat and the Q&A. We'll move through the other two panelists, and then we'll come through for Q&A all together. So at this time, I will hand over to Lacey Jaroski for your presentation.
All right. Hi, thank you. I'm Lacey Jaroski, and I live in Edna, Texas. Edna, Texas is, I would say, probably about 150 or about 100 miles south of Houston. In our county that we live in, it's a small county. We do have a county hospital, but they do not really serve pediatrics. I mean, if you go in because of a broken bone or something like that, they'll treat you. But we do get a lot of our doctor's appointments and everything about 20 miles away in a smaller or in a little bit larger town called Victoria. And so that's kind of where our story began with our daughter Sadie. She was born in Victoria in at a hospital, and she was twin A in a twin pregnancy. And pregnancy was great. They were delivered full term. Her twin brother was 8 pounds 6 ounces, and she was 6 pounds 6 ounces. She was quickly whisked away to the NICU for breathing problems. And she, at one point, they said that she had turned blue during a feed, and we really couldn't get a whole lot of answers. At one point in time when she was in the NICU, they told me they felt like she was not normal. And at that time, I wish they would have went ahead and sent her on to a higher level care in another town, but they didn't. Her Brady events finally resolved, and we were able to bring her home. 3 weeks into having her home, she started having these extreme startles. And I finally looked at my husband and was like, okay, we've got to do something. This is not right. This is not normal. We've got to figure this out. So we went to Corpus. They had the closest children's hospital to us, and they only had 3 neurologists there at the time. And one of them said, you know, her EEG looks great. It's not seizures, it's hypereplexia, which is another rare disease. And so we came home. He told us, just call if there's any more issues, we'll prescribe medication. So a week went by, things were getting worse. He went ahead and prescribed the medication. Medication didn't work. She continued to get worse and worse. So finally we took matters into our own hands, and we decided to travel to Houston. We went and sat in the ER with the twins, who were screaming and losing their minds. And because we were already being seen at another children's hospital, they pretty much said, well, there's not a whole lot we can do through the ER, because she wasn't actively seizing. You know, we just couldn't get any answers. And so they sent us home. And then it wasn't until about the middle of February when she had her first breath holding episode, and I had to call 911. They took her back to the ER, to the hospital where she was born. And that the ER doctor there said, you know, I'm going to say that she has pneumonia, but this is just what her lungs looked fuzzy, but that's just pretty much how the newborn's lungs were going to look. He said, but I do know that there's something wrong with her, and y'all need answers. Y'all need to get it figured out. So they transported her to Texas Children's, and that's where the testing finally began. We were able to get genetic testing, and within 2 weeks, we had a diagnosis of SCN8A, which is an extremely rare epilepsy. At the time of her diagnosis, she was only 1 out of 300. Now I believe there's close to about 700 cases in the world. But while we were there, we still felt like, what are we going to do? We live so far away from any specialty hospitals. You're having to travel 100, 150 miles just to get adequate care. So we were finally able to be given oxygen and a pulse ox. And at that time, we felt it was best to talk with our EMS department, and they were great. They had invited us to come talk to all of the paramedics, and she now has a SAIDI file on every ambulance, and they are all aware of, you know, her condition, the types of seizures she has. And it's just been very helpful, and kind of gave us a peace of mind that although we are very far from specialists, that at least if things were to go bad, we have their support. And I do call and keep them updated with, okay, her weight has changed, her medicine has changed, her dose has changed. And to me, I feel like living in a rural area, your EMS team is like your best friend, because they're going to be in there to kind of have your back if things go bad. But once we got her genetic diagnosis, we decided, well, she's rare, so we know we're going to have to travel. So if we're having to travel, we might as well find the best of the best and try to find a specialist. And so we actually see a doctor in Fort Worth at Cook Children's, which is about a 6-hour drive for us. And he sees her in person once a year, and we do the telemed one time also. So every 6 months we're seeing him. You know, we'll see him telemed, and then we'll see him in person. And I feel like if things were to go bad for her, he has already told us, go to your nearest hospital, we will fly in, we'll pick her up. But as far as blood work or any of that other stuff, we're able to get that done in the town, close by. That's about 20 minutes away. And I feel like although we do live in a rural area, knowing that they can fly in and pick her up, it kind of gives us peace of mind too. So, but if you have any questions, just let me know.
Thank you so much, Lacey. I think your talk is also generating a lot of questions here in the chat, and we'll definitely come back to you for some of those. At this stage, I will turn over to Roxanne Kogel, our final panelist.
Thank you, Kathleen, and thank you everybody for sharing. My name is Roxanne Kogel, and I'm going to share from a parent perspective. My daughter was diagnosed with epilepsy at the age of 2, and we live in the rural Midwest. And when I mean by rural, I mean I live on the home farm I grew up on, that was originally owned by my great-grandparents. And the closest 2 towns to where we live are only 200 people. So when she got diagnosed with epilepsy at the age of 2, we had to travel across the state, about a 3-hour drive, to see a pediatric neurologist. Her seizures were uncontrolled. She had multiple seizure types, and she would often have the cyanosis where she turns blue in the lips, and nobody could figure it out. About 2.5 years into having uncontrolled refractory epilepsy, we were sitting in the she had to go through repeated MRIs, and that's because she had her MRI imaging showed she had lesions throughout all the lobes in her right hemisphere, and they wanted to do periodic imaging to see if it was stable, because they didn't know if it was congenital or if it was a low-grade astrocytoma. And it ended up being stable. But 2.5 years into this, I was sitting in the EEG waiting room, and the radiologist come into the waiting room, and he goes, "Where is Mrs. Kogel?" And I raised my hand in this waiting room full of people. And he said, "What is going on with her daughter?" So I explained that none of the medications were working, felt like we were losing her. She had no quality of life, and her health just continued to deteriorate. And he said that he was seeing a lot of increased atrophy throughout her white matter in her right hemisphere, and he didn't know what was causing it, and that he thought it could be Rasmussen's encephalitis, which is a very rare epilepsy syndrome, but he had never seen it clinically in a patient. He had only read about it in a textbook. And as parents, that really scared us, that the radiologist was identifying something that nobody had seen before. And at this time, this was in 2008, and our daughter was 5, and there was no pediatric epileptologist in our state. It was just general neurologists. That's all we had. We didn't even know there was such a thing back then. But anyway, we did some research, and we traveled out of state. We found another pediatric epileptologist that had seen 3 patients with Rasmussen's, which was a pretty large number given how rare it is. And that was really helpful to get more information and to look at potential treatment options for that, which ultimately led to a right hemispherectomy brain surgery. But at the place we were at, they were wanting to do other protocols such as plasmapheresis, IVIG, steroids, which would take another year. But yet the epileptologist told us that he preferred to see the hemispherectomy surgery done with it by the age of 6, and our daughter was already 5. So anyway, at the age of 5, we went forward with the hemispherectomy brain surgery, and the pathology report showed she had the clinical symptoms and the glial cells consistent for Rasmussen's, but not enough inflammation to be conclusive. And they also found cortical dysplasia, but it was rare in the fact that it's the kind you cannot see on the MRI. So at that time, they didn't know if it was unilateral or bilateral. Well, her seizures were controlled. Life was good. We were able to work her down to 1 medication until she developed asymptomatic hydrocephalus, which anyway, ended up with a second brain surgery and endoscopic 3rd ventricular. She is 19 years old. She's doing really well. And in the early years, so not only connecting with an epilepsy specialist that had seen our daughter's type of rare epilepsy was very helpful. But back in 2008 and 2009, social media was brand new, but we did search online and we found one other family in our rural state, similar age to our daughter, that had the same rare diagnosis, that had just had the hemispherectomy surgery 6 months before. And that was a godsend. Connecting with another family, our daughters got to meet, although our daughter kept having seizures, so she didn't remember a whole lot of it. And that led us to being connected with the Hemispherectomy Foundation. And hemimegalencephaly is another rare condition, and that potentially leads to that surgery. And so with that organization, we were able to connect with even more families with that type of rare epilepsy and surgery, and to do research on trying to figure out outcomes for life after the hemispherectomy, which was very, very helpful. And now with our neurology visits with telehealth, and prior to so now in our rural estate, we have three pediatric epileptologists. They've been doing telehealth since prior to the pandemic, which is very helpful. But our daughter can be managed that way because she's well controlled with her medication, and to have to not do that 6-hour round trip drive all the time is very, very helpful. We still go in person when she needs to see her neurosurgeon along with that, but that's been a game changer for accessing the epilepsy specialist while from the home farm, really. So
Thank you so much, Roxanne, for sharing that insight. And I think some of the things that the three of you have spoken about from this lived experience are important elements. And I think people are very interested in learning more, epilepsy surgery and genetic testing. I'm seeing a lot in the chat about people having misdiagnoses or very late diagnoses to get an accurate picture of the cause of their epilepsy. You've each shared a little bit about your experiences there, but what might you advocate for other community members in trying to get these types of interventions or investigations done, recognizing the barriers in rural settings?
I would say not to stop with an epilepsy diagnosis, to always look for the root cause and offer that early to everybody.
And now with the Rare Epilepsy Network, it's a consortium of rare epilepsy organizations with that patient portal. And it's much easier with the technology and with that network to get connected with other family members and other individuals with rare epilepsies.
Yes, and I was just going to say, as soon as you do get an epilepsy diagnosis, just go ahead and try to find out the root cause of it. Don't just take it as, oh, your child has seizures and this is the way life is going to be, because there's got to be a root cause for it. And once you do get to find out what is actually causing the epilepsy, there are so many great foundations out there. Just in SCN8A alone, we have the Acute Syndrome Foundation, we have a private support group through that, and we also have the SCN8A Alliance, where that's tied in with the geneticist who discovered SCN8A, and we're able to do Zoom meetings with him. So once you get a diagnosis, I feel like you are able to be exposed to a whole new world and be able to connect with families and build these friendships and learn so much more from everybody else.
I would just make one comment from sort of the provider side, that it's a new world. It's a new world in epilepsy diagnosis in particular, and care, I hope, but the truth is in diagnosis. So while it used to be so complicated to order genetic testing, to obtain it, to interpret it, it's so much easier now. Probably only an epileptologist is going to say that, and maybe only an epileptologist at a higher level epilepsy center. But it's just, in the past just few years, has transformed how much easier it is. So I couldn't agree more. Keep trying, keep looking. And so our theme here is rural care, but if you don't have rural care, just as a general principle, I definitely say keep looking at higher levels of care until you get the care you need.
Well, and one more thing I wanted to add is our daughter's neurosurgeon that did her hemispherectomy surgery he wanted us to come back and see him at 6 months and at a year, but at the year appointment, he said, I now know all that I know. And I want you to keep coming back because at this point, we continue to learn from the patients and their outcomes. And that was really shocking to us back then, that we were at the point where we were teaching the surgeons and our doctors with the rare syndrome.
All of you make excellent, excellent points. And I guess I would add another question related to this, for families that are struggling to get to a comprehensive epilepsy center, or that next level up in care, what would you say are the most important things that they should be asking their local provider? And then from the clinical perspective, are there things families should specifically be looking to do? What's helpful for them to get the most out of their clinical encounters?
Well, one thing I would put a plug in for is that it's almost impossible for you to know if your hospital or a doctor is an epilepsy specialist or has access to the care and things you need. But we have a national organization that accredits epilepsy centers, the National Association of Epilepsy Centers, the NAEC. And there you can find an epilepsy center. That doesn't mean that's the best place for you, but to qualify to accredit as a level 4 epilepsy center, for instance, but even as a level 3, you have to have access to all the things that we're talking about. So separate from anything else, my personal soapbox is, so I would have said in my youth, go see your doctor and ask your doctor to refer you to an epilepsy center. Now I say, just call the epilepsy center and make an appointment. You don't, in most cases, that's going to be the quickest way to do that. So that's the way you can access it, separate from any other aspects. So for example, once you do have an unusual or rare condition, then you might want to go one place or another, have special interest in it. But just in terms of looking for the diagnosis, and regardless of the diagnosis, keep trying every day. My personal professional life's been spent saying, don't give up. We make people better every day, even after 20 years, after 25 years. So you just have to keep trying to make things better.
I think finding the right kind of doctor as a partner too, you have to think about the teamwork that it takes if you're stepping from one level of doctor to another. And that's a very delicate situation sometimes too, especially if you do need a referral from that doctor to do that. So just trying to find ways to be a good team player and, make them understand why you feel like you need to go to the next level or need outside help. Sometimes, they seem very willing to do it. The rare epilepsies are very daunting, I think, and overwhelming for some. And they're glad to push them on to somebody else. But finding that good balance of relationships is really important too, I think.
And I also wanted to reiterate the importance of epilepsy genetic testing, because out of those unknown causes, more and more genes are being identified all the time. And this past fall, there's updated guidelines for the genetic testing for people with unexplained epilepsy. And whether, you can do whole exome sequencing, whole genome sequencing, and a lot of these rare epilepsy syndromes are identified through advanced genetic testing. And the direction is really precision medicine with epilepsy. And as they get more data and more research, starting to figure some of this out, which is really helpful for patients.
Absolutely.
Yes, and I just wanted to add, when we didn't have the actual genetic diagnosis, she had been put on Keppra, and that actually is known in the SCN8A to cause more intense seizures. And that's where she was having multiple episodes a day of breath holding spells and then going into tonic-clonic. But as soon as we were able to get on the correct type of sodium channel blocker for her, that's when she began to experience seizure freedom. And she has gone 3.5 years now seizure free. And I feel like she's been able to grow and develop and keep up with her twin brother. And so that's why anytime I talk to anyone who has an epilepsy diagnosis, I say, even if you've had genetic testing and it didn't come back with an answer, it's constantly changing and they're constantly finding new genes. So just every day, keep trying.
One of the questions in the chat was about a couple of specific genetic disorders, and that they're the only person I know with it, and that might very well be true. even at a large epilepsy center. So I'd encourage you to take advantage of the internet. So I wouldn't trust everything on the internet, but for identifying groups of people that have common interests, it's fantastic. So certainly through the Epilepsy Foundation and the Rare Epilepsy Network, which now you know about today if you didn't know about before, but as testament to everyone else on the call, you know, the power is in connecting with other people who have a similar condition. And probably the easiest way to find that is through advocacy groups or through contacting, you could correct me if I'm wrong, Kathleen, but I think we're through contacting the Epilepsy Foundation or the REN.
Yeah, absolutely. Epilepsy.com/local is a great way to put in your zip code and get connected with your local office who can assist you in finding a provider in your area. And then the Rare Epilepsy Network site is rareepilepsynetwork.org. And they are, you know, as Roxanne mentioned, a very large organization of a number of rare epilepsy organizations constantly growing because, as Lacey said, there's new diagnoses coming along all the time. So both of those resources I would certainly recommend. And there's a question in the Q&A for you, Nathan, about, is there a standard guideline across practices for when genetic testing should be done when a child has seizures, or does, you know, can that vary?
Practice definitely varies. And among more recently trained or more high-level centers, then genetic testing at the time that epilepsy is diagnosed when there's not another cause would be very common. So the evolving or emerging standard of care is genetic testing when you first identify that there's no other obvious cause for it. And that's more true in children than adults for various reasons, mostly because genetic causes are most often manifest in childhood, but not always. So I'm kind of a funny practice. I see both, I've in my career seen both adults and children, but I'm really an adult neurologist. So I cross over a little bit. And the practice patterns are a little different, but in general, the emerging standard of care is to check genetic testing when another answer is not there. And maybe this is an opportunity for you to plug in. So someone mentioned that in their 20s, they were in a research study that a university that paid their hotel travel expenses, very helpful at the time. And so the opposite of rural care, I guess, in a field clinic would be in a research study. And so the other end of the spectrum, which in our cases all goes right together. So we send patients from our field clinics to our research clinic whenever it's appropriate for them and they want to participate. But I'd say, just as I think Glenna mentioned earlier, we're learning every day. Only we're going to learn is by research with people that have the condition to participate. So for people with epilepsy to participate, that's my plug for participating in clinical research.
Thank you. We are almost at time, so I'm going to bring us into the closing part of this webinar, but certainly thank you for everyone sharing your questions. I appreciate Dr. Fountain, Diane, Lacey, and Glenna, and Roxanne, and to all the participants for your interest and engagement today. Thank you also to our partners, Jazz Pharmaceuticals, Ultragenyx, and the Rare Epilepsy Network. This has been a great session with a lot of wonderful discussion, and the recording will be available in the next few weeks on Epilepsy Foundation's YouTube and social media channels. I wanted to share before we wrap up just a couple of more opportunities to consider for those on the line. We have a 24-hour, 7-day-a-week helpline available in both English and Spanish. You can reach out to them via a toll-free number and also from epilepsy.com. So please feel free to visit and consider us a resource for you with any questions you might have. Additionally, the National Walk, the Walk to End Epilepsy, is returning to Washington, D.C. on May 6th at Nationals Park. This is going to be the first in-person national walk in 3 years since before the pandemic. And so we'd love for you to visit walktoendepilepsy.org/DC to find out more and join in on this event. And then finally, I don't have a slide for this, but next Thursday, April 6th at 2 p.m. Eastern, we're going to be hosting another Zoom webinar on the topic of comprehensive epilepsy centers. And so, you know, this conversation is definitely related to ours today. So we'll share the registration link in the chat box and via follow-up email. Thank you again for joining us and have a wonderful rest of your day. Take care.
Thank you.